Thanks everybody for coming by. We're just going to talk a little bit about knee pain and a lot about the anatomy of the knee, so people can sort of understand what some of the terms that we use when we talk about knee pain and what it can mean, and then we can talk about knee pain relief strategies and what's out there. There's a lot out there with knee pain. Knee pain is probably second only to back pain in terms of symptom that most people have experienced in their life. So let's sort of dive right into it. See if I there we go. So as an introduction to myself, I'm an orthopedic surgeon with the ortho team at Stoughton Health. I was born and raised just outside of Milwaukee in Menomonee Falls, and I did 8 years of training here in Madison. I did undergraduate and med school in Madison, Wisconsin, and then I went down to Wright State for my training as a resident. And then my first year in practice was over at the University of Louisville during fellowship, and I've been up here in Stoughton since then. So in the first 3 years of practice, but I've been training in orthopedics for over a decade. Um, and my specialty is really hip and knee reconstruction. So I specialize in total knee replacement, total hip replacement, as well as revision, total knee and total hip replacement. So a lot of the stuff that I treat surgically is more chronic knee pain, long-standing knee pain, as opposed to sudden injuries. But we can talk a little bit about the differences between sudden injuries and chronic knee pain. And then um, I just also wanted to introduce sort of who the ortho team providers are. Myself, my partner is Dr. Ashish Rao. He is a sports medicine orthopedic surgeon, but he also does total hips and total knees as well. And then my other partner, Dr. Zachary Lind, he's a foot and ankle podiatrist. So he does foot and ankle surgery, all types of foot and ankle surgery. So together with Dr. Lind and Dr. Ravel, I think at the ortho team, we can provide a lot of the care that people need for the extremity. So we do a lot of from the hip down to the toes and from the shoulder down to the elbow and sometimes even into the forearm and hand. We can do that at the ortho team. So that's what we can provide for you if you're interested or if you just have questions. So knee pain. But again, we when we think about knee pain, it's one of the most common complaints and symptoms that people experience. And the knee joint is where the femur bone meets the tibia bone. The femur bone is your thigh bone. Your tibia bone is your shin bone. And it's a hinge joint, which is in contrast to other joints like the hip joint or the shoulder joint, which are both ball and socket joints. And I would propose to you that, at least in human anatomy, the hinge joint is more complex than the ball and socket joint. The ball and socket joint tends to be pretty intrinsically stable. Yeah, as you can think of almost like a ball sort of suctioning into a socket, it's intrinsically stable. Whereas a knee joint, yes, it only has to bend and extend, but you need to have sort of the quote unquote door stops, right? You can't extend too much, you can't bend too much, and you also have to it's more complex than that as well. So the knee, one of the reasons why people knee pain is more common than hip pain is because, in my opinion, it's actually a more complex joint. People as biomechanically. Also, you feel your knees a lot more than you feel your hips. You're from a sensation standpoint, as we walk, if you just are walking or walking up and down stairs, you have more nerves in your knee. You have more awareness of where your knee is in space compared to where your hip is in space. So it's just because you have more awareness of it, it stands to reason that if it has any internal derangement, you would be more acutely aware of it. Similar to the way if you have like a splinter in your finger, you can point exactly to where it is because you know exactly you have a lot of nerve endings in your fingertips. And so because you have more nerve endings and you have more sensation in your knee joint, it's another reason why people have more pain in their knee joint compared to, say, the hip joint. I mean, we'll talk about everything that's in the knee, but muscles. So the knee is not just where two bones meet. There's skin, obviously, enveloping it all, but there's muscles, there's ligaments, there's tendons. We'll talk about the cartilage and the meniscus and what that means. As an orthopedic surgeon, I'm a big believer in the importance of your muscles in terms of your knee function. And if you're going to highlight one muscle that you have to work on in order to maximize your knee function, it's going to be your quadriceps muscle. Okay. Your quadriceps muscle is your thigh muscle. It's called the quadriceps because it has four different muscle bellies. And that muscle is what allows you to extend your knee. It brings your knee from when it's bent into when it's fully extended. It makes it straight. And that the reason why that muscle is so very important is because that is a muscle that we use to stand up out of a chair. And that when in order to stand up out of a chair, that is how we function as humans. We don't work out the quadriceps muscle when we are walking. So if you're saying, well, I walk a lot, am I working out my quad? The answer is no. Walking works out your hamstrings and what's called your posterior chain. So when you walk, you work your calves, your hamstring, and your back muscles. So in a lot of ways, in order to maintain a healthy knee, you have to do dedicated exercises for your quadriceps more than just walking. Like I said here, the quadriceps helps you go up and down stairs, helps you get up out of a chair. These are everyday daily functions that if your quadriceps gets weak and you can't do those things, it makes life really hard. Um, you'll hear me sort of harken back on the importance of the quadriceps in terms of your knee health and your overall functional health. But all of your muscles that cross your knee joint interact and stabilize your knee joint. So without your muscles, you don't have a stable knee joint. Just like without your ligaments, you don't have a stable knee joint. Anything that crosses your knee is a dynamic stabilizer of your knee. That includes your quadriceps, it includes your hamstrings. It also includes one of your calf muscles called your gastrocnemius muscle. It's the large belly, muscle belly in your calf. That actually goes up above your knee. So all three of those muscles interact to actually stabilize your knee. Um, so that those are the muscles. What else is inside the knee? What's inside the knee is the meniscus, the ligaments, and then the cartilage. And the cartilage, I mean, so we'll take them one at a time here. But one of the things I wanted to highlight as we sort of go through some of this basics is sort of what a meniscus is and what it does. Because I feel like a lot of people think of the meniscus as almost like a cushioning to the knee. A lot of people think of the meniscus as a troublemaker in the knee. It's one of the things that causes a lot of pain, which is true. But it still remains a little bit of a black box to people. So we're going to talk a little bit about what it is. So this picture that you see here is actually as if you're looking straight down on the tibial plateau, which is the flat part of your knee. So you have your femur bone is a round part of your knee. It's like a ball sitting on a table. That's what your femur bone is. It's a round ball sitting on the table. So if you think about it, and I'm going to use this analogy a lot, but if you think about a ball that sits on a table, well, a single ball has one point where it's contacting the table, and all the forces are going through that one point. But if you're instead of sitting on a table, if you're sitting on more of a saucer, like a teacup saucer, instead of being one point touching the table, you have the whole ball touching the table. And it's such an important concept in terms of the biomechanics of the knee. Well, if you don't understand it, I'll try to explain it a little bit better later. But the meniscus is really what improves your contact of your femur to your tibia. And without your meniscus, you have just a single point of contact, like a ball sitting on a table. It makes you more unstable, and it makes you because the forces are higher, it increases your pain. So it's not just cushioning; it's also stability. That's what the meniscus does. Obviously, ligaments. ACL is a very famous one because it's very frequently torn in athletics. But your ligaments, you have two internal ligaments, including your ACL and your PCL. These are ligaments that stabilize your shin bone below your femur bone. You also have two outside ligaments. One's called your MCL, one's called your LCL. Those also stabilize your shin bone beneath your thigh bone. Cartilage is, well, I like to make the analogy of cartilage to a cue ball, right? It's a cue ball because it should be nice, smooth, and white, all right? Any roughness of the cartilage makes your knee unhealthy and it starts to break down. And instead of it being a nice cue ball rolling across the surface, it starts to scrape across the surface like sandpaper, and that causes pain as well. We think of cartilage, everybody thinks, oh, cartilage in my ear, cartilage in my nose. There's a whole bunch of different cartilage. And collagen is the main protein that makes up your soft tissues, including your cartilage and your skin and all, and your bone even is made of collagen. So cartilage is just one type of a protein called collagen, and it makes up the end of our joints and makes them a nice smooth cue ball surface so that they glide across that pool table nice and smooth. If the cartilage starts to break down, it starts to become more like sandpaper rubbing on that pool table in the analogy, which obviously you can imagine how much a pool table would be not working too great if you were rubbing sandpaper on it. So you need that cartilage to be a nice smooth cue ball. And this is just an illustration of sort of what that cartilage looks like. On the right side of your screen, you can see that the cartilage is that white smooth cue ball, and on the left side of your screen, you can see that it's all broken down and fragmented and cracked. And that's what happens when your cartilage starts to break down. It starts to look like that. And I mean, that's just a cartoon, but we have pictures of this stuff. When we put cameras inside the knee and look at it, we can see essentially what that picture is showing. Similar to if you're doing a total knee surgery, you open up the knee and look at it, you can see one side is all cracked and worn down, and the other side can be, like a cue ball, like healthy cartilage. So one of the reasons why we have knee pain is because of internal derangement in the knee. So knowing what's inside the knee and what can be deranged is how we diagnose knee pain. X-rays, I mean, as an orthopedic surgeon, X-rays are my favorite image modality. It's what we get all the time. I think in a lot of ways, X-rays are like your firstborn child as an orthopedic surgeon. You grow up with them, and they're very much very useful, and they have a special place in an orthopedic surgeon's heart. And so, I mean, there's an X-ray up at the top of the screen there where you see the bones meeting. Where the bones meet is called the joint. And you see the space in between the bones. That's called the joint space. And if there is joint space, that's filled up with stuff. And what it's filled up with is the cartilage and the meniscus. So on an X-ray, if there is joint space, we know that cartilage and meniscus is present. We don't know if it's healthy, but we know it's present. Whereas that's on the left side of that X-ray. On the right side of the X-ray, you can see that the joint space is gone, right? So if the joint space is gone, we know that the cartilage and meniscus is not present. The cartilage and meniscus has been worn away. It's been spit out. And when the cartilage and meniscus is not present, that's when you have that sandpaper rubbing on that sort of cue ball, the sandpaper rubbing on sandpaper, or sandpaper rubbing on the pool table. It's just grinding away, and it's a very rough surface, and that can cause pain for people. So that's the cartilage. So the meniscus is one of the things I want to take some time on, because I feel like a lot of people have heard the word meniscus. A lot of people have been told their meniscus is torn. A lot of people have had surgery on their meniscus. It's a fancy word that maybe a lot of people don't understand what it is. So I was talking about how the femur can almost be modeled as a ball sitting on a table, right? Because your tibia is a flat surface and your femur is a round surface. So the analogy that I thought was maybe helpful for some people in terms of understanding what the meniscus is. So if you have a marble, bear with me here with this analogy, but if you have a marble and you put it on the back of your hand, right? That marble is just going to roll right off the back of your hand, right? It's only because the back of your hand is sort of stiff and flat. That marble it's got that one little spot that's touching, and it'll just roll right off. Now, if you flip your hand over and put a marble in the palm of your hand, okay, I would propose to you that now that same marble, which rolled right off the back of your hand, it has a lot more surface area that's touching your palm, right? Now your palm is shaped like a dish. It's shaped like that teacup saucer, right? So that marble isn't going to roll right off. It's going to stay nice and cushioned on that palm of your hand. not just because your palm is softer and cushionier. And obviously, it's more like a pillow than the back of your hand. So there is more cushion there, which is part of it, but also because of its shape. So the shape of the hand stabilizes that marble. It gives it more surface area and makes it more of a softer landing. So it might be a little bit of a stretch, but I would propose to you that your meniscus makes that flat surface of your tibia, the flat surface of your shin bone that your round femur sits on. The meniscus makes it more like the palm of your hand. It deepens that surface. So not only is it sort of cushion, not only does it make it softer like a pillow, it also increases the surface area of the contact, and it stabilizes that ball on the tibia, right? Just like the marble isn't just more comfy on your hand, but it's also more stable, right? So I think that's a key thing that people don't realize the meniscus does. Not only does it cushion your knee, but it also actually plays a role in stabilizing your knee. And it decreases the pressure on your knee if you have a healthy meniscus. So hopefully that sort of sheds some light on the black box of what the meniscus is. And there's a picture there on the screen. It's really a semi-lunar or hemispherical triangular uh, dish that deepens your knee and makes it more like a dish as opposed to a flat surface. And then, I mean, we talk a little bit about the ligaments. The analogy I like to use with the ligaments is so your knee isn't locked together. It's a hinge joint, but it's not locked together like a door hinge where you can't pull them apart. If I pull your tibia on your femur, it's going to stretch and it's going to pull apart. They're not locked. What holds the shin bone below the thigh bone is your ligaments. And your tibia is almost suspended from these ligaments like rubber bands. Okay, so if these bands of tissue are torn, you can imagine how it can become unstable, and that's what happens when athletes tear their ACL or even any of your other ligaments. So the ligaments are another key part of the knee, and it just makes it even more complex, right? So it goes back to that thing that I first said. It's like it sounds like a pretty simple thing. It only moves in one direction. Either it flexes or it extends. It just opens or closes like a hinge, but it's so much more complex than that. So much more complex than a ball and socket joint like the hip, and so much more reasons to have pain. So from the standpoint of how do you know where your pain is coming from, one of the concepts I tell people in my clinic is that surprises people is that 10% of people with hip problems present with knee symptoms. What that means is there are people who come into my clinic who say, my knee hurts. And then I end up telling them, and we end up finding that the reason why their knee hurts is actually coming from their hip. So, as a surgeon, I might see 20, 30 patients a day in my clinic. If all of them come in and have knee problems, two or three of them are actually, it's coming from the hip. The 10% is not that small of a percentage, and it happens daily in my practice where I see people coming in saying, my knee hurts. And then we end up talking more about their hip than their knee. So it's just a little aside there. It's not really, about the knee, other than it can be surprising sometimes how a patient will say, or even I'll say, oh, it's my knee hurts, but it's actually coming from derangement in my hip. So just an aside there. And then what are the types of pain? What are the types of pain that you have when you have knee issues? It's mostly pain going up and down stairs, pain rising from a chair, pain when walking long distances. I mean, it goes back to that muscle conversation we were talking about earlier too, right? So, what did we talk about? What does the quad help us do? The quad helps us go up and down stairs. The quadriceps helps us rise from a chair, right? So the hamstrings are what we use when we walk long distances. These are the muscles that cross our knee joint. So if we have derangement in our knee joint, it's the same things that cause the pain in the knee that the muscles do that cross the knee, right? It stands to reason, I guess. Intuition makes sense here. So the reason why I harken back to the muscles, and you'll hear me say this a lot, is because if you're having issues going up and down stairs, or if you're having issues getting up out of a chair, you should work out the muscles that you need to do that. It doesn't mean it's gonna solve your problem per se, but if it's the stronger your quad is, even if you have a terrible knee, the stronger your quad is, the easier it's going to be to go up and down stairs, the easier it's going to be to rise from a chair, because that's the muscle that you use to do it. And it also, like I said, because it is part of what stabilizes your knee, your muscles are part of what stabilizes your knee. A lot of times, these exercises can sometimes take away some of the pain. Not always, but sometimes. So, in orthopedic surgery, we oftentimes are talking a lot about exercises and physical therapy, and it's all because they're all connected. You can have internal derangement in your knee, but one way to make it easier to function is to make your muscles stronger. That is the thing that your knee needs to do, like go up and down stairs or rise from a chair. So, I mean, it's very common for people to say it hurts when I go up and down stairs or rise from a chair. So, the first thing that we talk about in my clinic is what are we doing for quadriceps strengthening? How do we know if it is the meniscus? How do we know if the pain is coming specifically from the meniscus? Or how does a surgeon know? Well, a surgeon tends to identify if pain is coming from the meniscus, specifically if you have clicking, catching, or locking in the knee. Okay. And that doesn't, so sometimes it can be coming from the cartilage, but a meniscus that is torn will oftentimes catch and lock and cause your knee to literally lock in one spot as the meniscus flips back and forth. So, um, obviously, if the meniscus is torn, it's not doing its function. A torn meniscus is not a functioning meniscus, which means not only is it not cushioning the knee, but it's also not stabilizing the knee, like we talked about. It's making your knee feel more like a marble sitting on the back of your hand as opposed to a marble sitting in a comfy palm. So it's just so important. The meniscus is so important in knee function. And then, so how do we treat the pain? So, um, from my perspective, um, there's so from my perspective, from a knee perspective, there's two different types of pain that come into my clinic. Okay. One of the type of pain that comes into my clinic is acute pain, meaning sudden pain. I injured myself. I fell down. I couldn't get back up. This tends to be either like a car accident or it's a higher energy injury. These are people like the athlete who tears his ACL. These are people that's called acute pain. Like I was okay and then I wasn't. You had a sudden injury. And then the other type of knee pain is more long-standing chronic pain. Okay. Long-standing chronic pain is, well, it just sort of started out of the blue and it slowly got worse. It comes and goes. I have good days and bad days. That is probably the number one thing I hear from people. It flared up on me and now I can't walk. I don't know why it started. I didn't fall. I didn't do anything wrong. It just came out of the blue. That's how knee osteoarthritis comes up. Okay. That's more chronic pain. Okay. So what can you do before you even go to the doctor to treat your pain? The first thing you can talk about is your quadriceps muscles, right? I talk to people, there's two different ways I talk to people about the quad. One would be that if somebody said, well, I'm really active, doctor, why would I have to do exercises? I stay really active. Um, my response would be that if you have a knee injury and you're a football player or Michael Phelps or a high level athlete and you hurt your knee, that football player might be able to squat 600 pounds, all right? But they hurt their knee, so they go to the trainer, and the trainer gives them exercises for their knee. It doesn't matter if you can squat 600 pounds. If you have pain in your knee, you got to do exercises for your knee, okay? That's part of the treatment for the highest level athletes and everybody else too. That's how we treat everybody, right? So it's just so if you just say, well, doc, I'm really active, I don't think exercises are going to help. my response would be exercises help everybody. The second thing is, it's the importance of the quadriceps with regards to function. It's the as opposed to the athlete who says he's really active. It's the person who says, "Well, man, I have a lot of trouble even just getting up out of a chair. How am I going to do these exercises? Is it worth even trying?" And the answer is yes. And it's because you're in order to maintain your independence, you have to be able to rise from a seated position. Okay. This is one of the key things that as humans we have to do in order to maintain our independence. So literally in my clinic, I tell people that your quadriceps muscle is your independence muscle. All right. The stronger your quad is, the longer you will remain independent, which I think is should be motivation for everybody to start doing quadriceps exercises right away, right? And it does help people, and it offloads your knee, it stabilizes your knee. It might not help a meniscus tear, right? It might not help a cartilage injury or osteoarthritis. Like it doesn't change the way the x-ray looks, is what I tell people. Exercises don't change the x-ray. Exercises don't change the the meniscus tear. But what do exercises do? They stabilize your knee, they make it stronger, and if your knee is stronger and more stable, then your meniscus doesn't have to work as hard. Like we talked about, part of your meniscus function is to stabilize your knee. Well, if your muscles say, I can do that on my own, the meniscus doesn't have to work as hard. The meniscus tear doesn't matter as much. Um, Data would say that if you have a chronic meniscus tear, meaning it was a degenerative in nature, you didn't have an injury, it sort of happened over time. Over 80% of chronic meniscus tears don't need surgery. They get better with exercises alone. Okay. That doesn't mean some of them do need surgery. We do surgery on meniscus tears, but over 80% of meniscus tears don't need surgery. All right. The next thing, other than exercises, the next thing you do would be like anti-inflammatories, like um, Aleve, ibuprofen. Those are some of the most common over-the-counter ones. There are also ones that are available for prescription that we can talk about. If we come to my clinic, we can talk about the positives and negatives of the different anti-inflammatories. But anti-inflammatories truly are the workhorse of orthopedics because the reason why your knee hurts is because it's inflamed. Inflammation is your body's response to injury. Okay. If you jam your finger, it swells up and it hurts, right? Well, the swelling and the pain, that's what inflammation is. And if you have like a degenerative meniscus tear or osteoarthritis in your knee, it's like you're jamming your knee every step. Okay. So if you jam your knee every step, your body's going to send fluid and pain receptors to that area, just like it would if you jammed your finger every step, right? Your finger would swell up and be painful. So what do? You can't change the x-ray with a pill, but what you can do with a pill is turn off your body's response to you jamming your knee. So you take an anti-inflammatory, you're still jamming your knee every step, but your body doesn't notice it anymore. You're turning off that response. I equate it to like water on the fire, right? The fire is your inflammation and your osteoarthritis. You pour water on it, the fire goes out. That's good enough. Now, if the water runs out, the fire comes back. That happens. Every single medication that I know of tends to wear off, right? But like we use them because they're easier than things like surgery, right? Injections are another way to deliver medications to the knee, right? If you do a knee injection like a steroid injection, it's an anti-inflammatory directly at the knee. So it's stronger than just a pill, right? Other injections like hyaluronic acid injections or gel injections, these are less anti-inflammatory. They're more like equated to like putting oil in your car, right? Well, you say, well, it's like sandpaper rubbing on sandpaper. If you inject something that's like oil, maybe it's not going to be sandpaper like sandpaper anymore. And sometimes that works for people. Sometimes it doesn't. None of the top three on this list, exercise, anti-inflammatories, injections, they don't change the way the x-ray looks. They don't change the way, you know, the internal knee is. The only way to change the way the x-ray looks is to do surgery. Okay. So what surgery do I do? I do total knee arthroplasty, which is what you see on the right there. That is not one of my knees, but um, that is total knee replacement, where they go in and you take out the cartilage because the sandpaper rubbing on sandpaper is it hurts too much. The only way to change it is to create it into a surface that is smooth again. We can't put cartilage back on the knee. It's not, we haven't figured that out in 2026. But what we have figured out is metal rubbing on plastic feels a whole lot better than sandpaper rubbing on sandpaper. So that's what a total knee replacement is. It's converting sandpaper on sandpaper to metal on plastic, nice smooth metal on plastic. So that's what I do. And again, I just go back to the first thing I would do if my knee hurts. I would start working out my quads. When my wife's knee starts to hurt, I make her start working out her quads. She doesn't like me for it, okay? But that's what we do, right? If our knees start to hurt, we have to work out the muscles that cross the knee, all right? I mean, that if you try that and it doesn't work, that's what I'm here for. I'm not here to tell you that it works for everybody, you know. You know, if it worked for everybody, I'd be out of a job. But it's the first step in treating knee pain. It's really working out your quadriceps. So that's all I had. I'm happy to talk a little bit more about um, any of this stuff if anybody has any questions.
Well, I think that's pretty ironic that your last slide is about quadriceps and there's a question in the chat. Can you see the chat or do I need to read it?
I should be able to. I don't see any questions in the chat.
Okay, it says private. It might be somehow set up that way. So one of the questions is, what does he recommend to strengthen the quads?
That's a great question. All right. So, and there's a lot of different ways to do it that have worked really well for a lot of people. Um, so there's two exercises I teach to almost every patient in my clinic. Okay. One of them is called a quad set. All right. It's one of my favorite exercises for a lot of different reasons, but um, I'll try to list them for you. One of them is this exercise is a non-weight bearing exercise. Okay. So if you have knee pain and it hurts to walk or it hurts to stand, you say, Doc, I can't do those exercises. It hurts too much. Well, this one, you don't have to walk. You don't have to stand. You can do it sitting in a chair. Okay. It's all you need is a chair. Okay. You do not need any fancy equipment. You do not need any, fancy gym membership. All you need is a chair, which are pretty widely available. All right. And then third is it also works on range of motion. All right. So what is a quad set? The seated quad set is when you're sitting in a chair, you straighten out your leg. Pretty simple, right? Well, then once you hold it there and you feel pretty comfortable, now you lift it up as high as you can and you hold it there. I'm doing it right now because I'm a goof, but so you lift it up and you hold it there. So you get the back of your thigh off the chair. All right. And you hold it there. What I tell people to do is you hold it there. If you can hold it through a full commercial break, you're stronger than I am. Okay. That means that it's pretty simple to get a good workout in your quad. Like a commercial break's what, 2.5 minutes? Okay. So you hold it there until your quad starts to shake. Then you put your foot back down and relax, and then you do it again. Okay. That's called a quad set. You do not need ankle weights. You do not need fancy equipment. All you need is a chair and the time of 2.5 minutes. So that's my favorite for a lot of different reasons. So quad sets, that's what my wife and I do when she starts getting pain. But what else? So chair squats would be another one, right? Chair squats are literally you don't use your arms, you stand up from a chair, you sit back down and you do it again, right? So they're so important to maintain your independence. If you can stand up from a chair 10 times without using your arms, I mean, that essentially guarantees you that you'll keep your independence. It's just what it is. I mean, the main reason why people lose their independence is because they have difficulty getting off the toilet seat. So if you can stand up without using your arms, you're avoiding the main reason why people lose their independence. Um, so chair squats and quad sets are, I teach those to almost everybody in my clinic. If you ever meet someone in my clinic, ask them if they talk to me, if I talk to them about chair squats and quad sets, because I often talk to people about chair squats and quad sets. A recumbent bicycle is really good. So if you, now that is obviously a little bit more costly, or you need a gym membership. If you get to a recumbent bicycle where you're leaning back and doing a full revolution of your leg, not just a small little stair stepper type thing where you're sitting down. I know sometimes you can see those ads on TV where they'll give you like just like a little bit like that. I don't want you to do a little bit like that. I want you to do a full time around. Okay. If you can do a full time around with your leg during a recumbent bicycle for 20, 30 minutes a day, that can be really, really good for your quads. Um, and I mean, that would be the three I would start with. Because a lot of times people have knee pain, so it really hurts to do more weight bearing exercises. So recumbent bicycle and quad sets, if you can work your way up to chair squats, that'd be great.
He also asks, what if doing squats doesn't hurt, but stairs do?
So so that's going to be part of your knee pain, right? So if doing squats doesn't hurt, that's wonderful. That means that you have good, strong quads. All right. Now, these exercises are not foolproof, right? You can have really good, strong quads and still have knee pain coming from one of those reasons, right? It could be because the cartilage is broken down, or because you have a meniscus injury. Um, but so it hurts when you go upstairs because of that. You know, so if you have good, strong quads and you're still having pain going downstairs, then I mean, come to my clinic. We'll talk about it, right? We'll talk about, what are the options we can do to address this knee pain? How can we figure out what's going on, and then, you know, try to make going up and downstairs not hurt? Because in my office, pain going up and downstairs is considered severe, and the reason why it's considered severe is we do stairs every day. Okay, so if you only have pain when you like go run 2 miles, that's that can be significant. I'm not belittling it, and I'll help you with it. But that's not as severe as having pain every time you go up and down stairs. Well, you go up and down stairs all the time. You can avoid running 2 miles pretty easily, right? So, in my office, if you have pain going up and down stairs, you have pretty severe symptoms already. So maybe just doing some quad exercises isn't enough.
Thank you. Are steroid injections after draining a Baker's cyst recommended? Age and arthritis are involved.
So a Baker's cyst is you get a Baker's cyst in the back of your knee, oftentimes on the outside or lateral side of the knee, just underneath the lateral gastroc, which is your calf muscle. Okay, that's what the most common Baker's cyst is. A Baker's cyst is due to an imperfection in your joint capsule. Okay, so maybe I can find a picture here. Um, so your joints, if let's see, no. So your joint, if I'm doing surgery on your joint and I cut your skin, and then I'm looking at your knee, I'm not looking at your knee yet. I'm looking at your joint capsule. Okay. Your joint is actually encapsulated or surrounded by a joint capsule. All right. Every single joint on earth is, at least in our bodies. Our fingers have joint capsules. Our shoulders have joint capsules. Our elbows, our knees, our hips. So if your joint capsule is torn or has an imperfection in it, the fluid that's naturally in that capsule leaks out. Where does it leak out? It leaks out the back of your knee just below the gastroc, which is where a Baker's cyst is. So the reason why you have a Baker's cyst is because you have an imperfection in your capsule of your joint. Okay, so why do you have an imperfection in the capsule of your joint? Well, the meniscus connects to the capsule. So very likely you have a meniscus injury that tore the posterior capsule or the back of the capsule of the knee. And now the fluid is leaking out of your knee into the Baker's cyst. So what does all that mean? It means that a Baker's cyst is a symptom. It's not the pathology, right? The reason for your Baker's cyst is because your capsule is imperfect. It has tears in it. The reason for your capsule having tears in it is because of your degeneration in your knee. So the problem is actually your degeneration in your knee, not your Baker's cyst. One of my mentors said that the Baker's cyst is smoke. It's not the fire, it's just smoke. So you can aspirate, you can drain the Baker's cyst, you can suck that smoke away, all right? But the moment that needle comes out, the fire's still there, the smoke will come right back, the Baker's cyst will come right back, okay? The Baker's cyst is a response to what's going on inside the knee. Um, so, does a steroid injection help with a Baker's cyst? Yes, it does. Because the reason why you have fluid in your knee, well, every joint has fluid, but you have more fluid in your knee because that's what inflammation is. Inflammation is when you jam your finger, it swells up, right? So, inflammation is fluid going to the area of injury, all right? So, if your Baker's cyst is going to be much larger if you have more inflammation, okay? Because that's more fluid. That's what a big cyst is. The cyst is fluid. So, how do you decrease fluid? You can decrease fluid by using an anti-inflammatory like a steroid injection. A steroid is an anti-inflammatory. That's what it is. So, Advil and Aleve, ibuprofen or naproxen, these are all um, non-steroidal anti-inflammatories. That's what they're called. They're called non-steroidal anti-inflammatories. Well, given that's what they're called, it stands to reason that steroidal anti-inflammatories exist. So a steroid is the same thing as a lead. It's just stronger and it's delivered right at the knee joint. So it's an anti-inflammatory. That means it reduces swelling. If it's reducing swelling, it should reduce the size of your Baker's cyst.
All right. What is your thought on taking collagen supplements, such as vitamin protein?
Collagen supplements.
Mm-hmm.
So, I mean, from a supplement standpoint, I don't have strong feelings either way. Um, you're definitely talking about prevention at that point. Okay. You're trying to prolong longevity of your cartilage if you're taking collagen supplements. Um, it's not going to, I've never seen collagen supplements change the way an x-ray looks. Okay. I've never seen a supplement take somebody who had a really, really bad x-ray and change it to a really, really good x-ray. Okay. Doesn't mean it can't prevent worsening, right? If you have whatever cartilage you have left, whatever collagen you have in your knee, you take collagen supplements, it could prolong its longevity, but it's not going to reverse anything.
Do wall fits help quad strength? And do you have suggestions for people whose knees are double jointed and can hyperextend?
So, what was the first question?
Do wall sits help quad strength?
Yes, yes, they do. Um, yes, wall sits would help quad strength, very much so. Double joint and hyperextension. From the standpoint of hyperextension, a healthy native knee has about 3 to 5 degrees of hyperextension. Um, so like if you grab, you know, 50, 18-year olds off the street and lay them down and see how much hyperextension do they have, almost every single one of them will have a certain amount of hyperextension in their knee. Okay. Now, if you have more hyperextension in your knee, like say 5 to 10 degrees of hyperextension, you start falling into a category of like ligamentous laxity or just stretchy ligaments. Um, so, uh, if you have stretchy ligaments, your whole joint is going to be stretchier. It's going to be more unstable. Um, so, does that well, all that means is it probably means you have to work harder to get it stable with your muscles have to be stronger in order to achieve stability as opposed to somebody who has tighter joints or tighter ligaments. Um, you know, that doesn't mean, and again, it's all on a spectrum of how bad and severe is it. Like we don't, for native knees at least, you don't necessarily do surgery to take away range of motion. um, because that's all you're doing is it's not frequently done, I guess. There's times we do that in replaced knees, but not in native knees. So for somebody who has like Ehlers-Danlos syndrome or ligamentous laxity, I would say that it's even more important to do exercises. there might be a ceiling to how much relief you'll get from exercises because of your laxity. But I mean, you got to at least reach the ceiling and try to bust through it if you can.
Here's another good one. Can you take an anti-inflammatory daily?
Yeah, I mean, yes, you can. And so a lot of the over-the-counter ones, um, you take with food, and they're pretty short acting. So Aleve is for 12 hours, and Advil is for 8. Yes, you can take it daily. If you're requiring it on a scheduled basis for over a week or two, I'd probably, give us a call and see if there's anything else we can help you out with. Um, but because there's safer ones that are more prescription that you can take once a day that have a little less side effect profile if you have side effects. But yeah, if you're requiring scheduled anti-inflammatories due to pain for like over a week or two, I'm happy to see and talk to you about other options.
What is your opinion of nerve block for knee OA?
It doesn't change the way the X-ray looks. Unfortunately, I think we found that a lot of the nerve blocks are also only temporary. If it helps you, you can absolutely do it. I'm not against it by any means. Um, but I think we found that some of the genicular nerve blocks that people do, um, they get temporary relief, not permanent relief. Um, so how would I use it? I would use it the same way I would use a steroid injection, right? A steroid injection is also temporary relief, right? So we give you temporary relief and go work on some exercises, and hopefully that relief lasts longer because you're stronger once you're through, once it wears off.
What are the main things to do to keep your knees healthy?
I mean, quadriceps exercises. I know it's a little bit of I'm not trying to be a parody of myself, but like it's truly the stronger your quad is, the more you'll offload your knee. Um, Beyond that, I mean, trying to keep your weight as low as possible, like getting a BMI that's less than 30 would be really helpful. Um, and um, I mean, it depends a little bit on what's going on with you specifically. Like if you're somebody who has low bone density, you actually want to do more weight bearing exercises. Okay. If you're somebody who has really bad osteoarthritis, who it flares up when you walk too much, you probably want to do less weight bearing exercises because weight bearing exercises flare up your pain. Um, you know, from the standpoint of how do we prevent osteoarthritis definitively, we can't. In a lot of ways, it's the people who get arthritis are mostly because of their genetics. I've used this in talks before, but I tell people, why did I get arthritis at age 65? Well, why did my hair turn gray at age 30? Because my dad's hair turned gray at age 30. So you might get arthritis in your knees at age 65 because that's when your mom got it. Um, in a lot of ways, we aren't really meant to have hair color for our whole lives. And we also aren't really meant to have, cartilage in our knees last forever. It sucks. I wish it did, but it also put me out of a job. So I don't know.
Are standing squats good to do when you have osteoarthritis? I exercise 5 days a week, and the more they involve squats, the sore I usually am going to get.
Correct. So yes. So yes and yes, both. Um, Standing squats can flare up your osteoarthritis 100%. And so we were just talking about weight bearing exercises on your feet can flare up your knee osteoarthritis, which sucks, right? Because I tell you, go do squats, and then you say, but that hurts and it makes me worse. Um, and that does suck. I agree. So that's why I give you other options, right? The quad sets are non-weight bearing, a way to get your quadriceps stronger. Recumbent bicycle is a non-weight bearing way to get your quadriceps stronger.